We shall wait for another 2 minutes. Let someone others also join. Ankur, let's start, Ankur.
Yes, ma'am. People have joined? Okay.
One person has joined in addition to us.
Right. I think Neeraj, you can begin because
Okay, sir.
yeah, go ahead, go ahead.
Okay, sir. Basically, sir, today's journal club topic is use of recombinant factor 7 versus placebo for the spontaneous ICH within 2 hours of symptom onset. It's a FATTERS trial, a multicentral double-blind randomized placebo-controlled phase 3 trial published in the Lancet February 2026. So now coming the introduction part of this trial, sir. The spontaneous has to the initial hematoma volume and the subsequent expansion. Most hematoma expansion occurs within the first 2-3 hours after symptom onset, creating a narrow window for hemostatic intervention. Recombinant factor 7 had previously reduced hematoma growth but did not improve the functional outcome when given within 4 hours and increased the arterial thromboembolic event, leading to the recommendation against routine use. Post-hoc analysis, 1 minute. Post-hoc analysis suggests the potential benefit in ultra early time in those patients who receive the intervention within 90 minutes and in those patients who have a spot sign positive in CT angio. Now, sir, what is the hypothesis of this trial? Hypothesis does a dose of intravenous recombinant factor 7, that is the 80 microgram per kg, maximum 10 mg, given within 2 hours of onset or last known well improve 180-day functional outcome after spontaneous ICH with placebo while reducing the ICH and the IVH growth. Now, why is this important, sir? So because I am totally depend on demand size. If we stop breeding early, we will get a better outcome. So, sir, because ultra early hemostasis could convert a biological effect to reduce into the recovery, shifting in acute therapy of ICH because time is brain in the ICH. On the other hand, definitely neutral or harmful finding would prevent off-label use potent procoagulant with meaningful thromboembolic risk. Off-label use means that we should not use unapproved indication. Recombinant factor 7. Recombinant factor 7 is a synthetic version of human coagulation factor 7 used to control severe bleeding. Its mode of action is it activates the extrinsic coagulation pathway. It binds the tissue factor at injury site and activate the factor 10 to activate the factor 10, lead to rapid thrombin generation, which lead to fibrin clot formation. At higher dosage, it can directly activate the factor 10 even without tissue factor. Common preparation available in the market like Aptaga Alpha. Indication approved uses in hemophilia A with inhibitor, hemophilia B with inhibitor congenital factor 7 deficiency, and Glanzmann thrombocytopenia, etc. Off-label use, we will use in massive hemorrhage like trauma and surgery, ICH, liver failure related bleeding, post-cardiac surgery bleeding, Dose typically 90 microgram per kg IV bolus, repeated every 2-3 hours if needed. Now, what is the methodology of research question is in adult with content ICH table within 2 hours, does recombinant factor VII improve ITD outcome compared with the placebo? And what are the effects on hematoma growth and thromboembolic harms? It's a multi-center international double-blind randomized placebo-controlled adaptive phase 3 trial, emergency enrollment pathway including mobile strong unit and ICU unit level aftercare treatment is there.
Neeraj,
Now, sir,
Neeraj,
population involved
just
in this.
pause.
Ma'am.
Neeraj, just pause and explain each of the
Yeah.
terms, please. The study design, explain
ma'am?
all the terms, please. It is a double-blind, placebo-controlled phase
Ma'am, it's a
3
double
adaptive.
blind. It's a double
Mhm.
blind. Ji, ma'am.
That
It's a
means,
double blind, randomized, placebo-controlled adaptive phase 3 trial.
so double-blind means what?
Ma'am, double blind means the participant as well as the researcher or the analyst, they don't know what kind of drug should be given to what person.
What is adaptive and phase 3?
Adaptive phase 3 trial, ma'am, two more trial already done in the past, ma'am, phase 1 and phase 3, which are totally failed because in that trial, the intervention period is more than 4 hours.
No. Phase 1, phase 2, phase 3, what is the difference? When does a trial go into phase 3 and why is it conducted?
Ma'am, because in phase 2 and phase 1 trial, will give a drug after a intervention period of 4 hours. That's why in this study will give a drug within 2 hours. With ultra period.
Phase 3 is when you actually give it to a large patient population in the most pragmatic way. It will be used if it gets successful and goes to approval, FDA approval. In that circumstance, what will happen? You are trying it out in a trial manner at this stage. So suppose there is, you want to introduce a new drug into the market. You have to first check whether it is feasible to do the trial. Is it harmful? So those kind of questions will be answered in phase 1, phase 2. Phase 3 is
Okay.
actual dose, side effect, those to be studied. Okay. And what is
Okay.
adaptive? That is not always seen, no? Adaptive RCT, that is a very unique thing to this trial. So what's the benefit?
Yeah.
So adaptive means
Yeah.
usually RCT design is very rigid. There is an inclusion, there is an exclusion.
Okay.
Someone meets an inclusion criteria, he's in. Doesn't meet, out. But here you are ready to, as the RCT progresses, you are ready to change and adapt according to what you're seeing. So as you read this trial, you will see they changed it to 70, cutoff of less than 70. There was interim analysis showed 80, above 80, it was harmful. So they stopped enrolling that. Those kind of flexibility in the study methodology is available in an adaptive trial. So it is more pragmatic, which you will be able to use it in real life. Yeah, continue.
Got it, ma'am. Population in this trial are the adult population of 18 to 80 years of age with spontaneous ICH on the baseline CT. ICH volume should be 2 to 6 ml. Glass scale should be more than 8 and it should be treatable in 120 minutes onset. ICH also ICH permitted if there is a limited less than 2/3 part of 1 liter ventricle involved, less than 1/3 part of both the ventricle involved. This study also have some exclusion criteria like the ICH due to secondary or the structural causes, anticoagulant, pre-existing disability, or the ranking scale more than 2, brainstem hemorrhages, symptomatic thromboembolic or vaso-occlusive disease within 90 days, like cerebral infarction, MI, or MI, etc., and plan for care. Now, what is the intervention in this trial? When we use a recombinant factor 7 dose of 80 microgram per kg, maximum 10 mg, administered intravenously over 2 minutes. IV administration, private clinician, assessor, both are blind, with interim analysis conducted by an unmarked statistician, and data set both independent of trial conduct. This is a trial flow of concert diagram. We show we actually take a 3,288 recipient screening for the eligibility. 1 minute. Screening for the eligibility, 62 are excluded. So total we will got 620 random patients who are eligible and consent taking. This
Voice is breaking in between.
Neeraj, we can't hear you.
hello.
Neeraj, we can't hear you.
Am I audible, sir?
Yeah, now yes.
Ankur sir, are you asking something?
Please be loud.
Yes, now
Try
we
to
can
be
hear
loud.
you.
Share your screen first.
I'm already saying, sir.
We can't see it.
Is it visible, sir?
No.
1 minute, sir. Now you see, sir?
Yes.
So, sir, out of 298 in placebo group and 328 participant in the intervention group, 22 are died, 3 lost to follow-up, and 3 withdrawal the consent. So we will get 270 complete the study in the placebo group, and in intervention group we'll go 3 complete the study. Out of, but we will study all the participants in this group, that is 298. Out of which 12 are excluded from per protocol population. So finally, we'll got a 286 included in per protocol analysis. In the intervention group, out of 303 complete the study, will analyze total 328 individual included in the intention to treat analysis. Out of
What is intention to treat? What is per protocol?
Population with
Neeraj?
so intention to sir. So intention to treat is it is a analysis of patient in the group. They were originally, no matter what later, either they switch the group or they drop out the group or they did not receive the treatment. We will still they still analyze in the same group, sir. And per protocol analysis include all the participants who strictly follow the protocol of study, including sir, is exclude the those who did not adhere the study or drop out or the violate the study protocol. So basically, the intention to treat protocol is advantage. It maintain the randomization and it's reflect the real world practice and avoid the bias. But the per protocol analysis, it has no preservation of randomization, no high risk of bias, and there is no real world reflection. But its advantage is show the true efficacy of the drug in a clinical practice.
So ITT underestimates, whereas OTT, this per protocol overestimates. Okay.
Okay, sir.
Go ahead.
Now statically, they initially for 3 participant group to detect 10% absolute increase in good clinical outcome, and then standard and for a value of 0.05, which predict the type 1 error. The samples was further increased to 860 to account for 10% dropout rate. It could further expand to maximum 1,330 based on active re-estimation, which allow the researcher to adjust the trial size while it is still running, sir. So this clinical trial also having some stopping rule, and the study also having some stopping rule if the conditional power drop below the 0.20, that is below the 20%, sir. So the trial includes some safety valve to determine whether the trial continue or stop the early, because if we got the outcome is not effective for intervention group, so we'll stop the trial earlier. Like futility stopping, sir. If the conditional power drop below 0.20 means there is less than 20% chance the trial will succeed, it will stop, because the treatment likely does not benefit the participant. Similarly, sir, superiority stopping also is there. If treatment is overwhelming success early in period, they can stop via O'Brien-Fleming boundaries to stop the trial. Follow-up period, sir. Will we follow the participant imaging at 24 hours or earlier if surgery is required, or clinically follow the participant at day 30, 90, and 180? So this is a baseline patient characteristic should is ethnicity and race. So as you see in age, so as you see in the age group, both are very similar in age. Both groups are very similar in age. The mean is 16 placebo group and 61 in intervention group. The majority of participants in both the age in both the group are below 70. Like this, 78% and 73% in the age of below 70. Now this regarding the sex, population of male participants in this, approximately 60 to 65% are male, remaining are the females. The vast majority of participants identify as non-Hispanic, as you see that 91% and 90% in both the group. Regarding the race, this is a racially diverse cohort with a significant Asian representation. Asian population is more in both the groups, sir, 57% and 53%. This is another baseline characteristic of this study, sir, which show a pre-stroke modified ranking score, a time between the stroke onset and administration of drug, ICH volume and IVH volume, and NIH score, and baseline Glasgow Coma score. So basically, it's this chart so also 90% of patients in both the group had a MRI score of 0, means majority of the person were fully independent and symptom free before the onset of stroke. As you see, the time between the stroke onset and the administration of drug was approximately 99 to 101 minute, that is within 2 hours. This suggests the study is looking at hyperacute treatment where time is brain, and intervention happen in the period of 2 hours. Now, in view of ICH volume, the brain imaging characteristic showing the ICH volume in ml. In ml, the average was around 16.5 and 16.9 in both the group. The small amount in the group, and the small amount of IBH volume is also seen in both the group. Now, regarding the Glasgow Coma scale, sir, GCS assess the neurological status based on the eye, verbal, and motor response, ranging from 8 to 15. Had a score of 15 indicating they were fully awake and conscious. A small score of 2% of 8 GCS scoring indicating a severe impairment in the consciousness. NIHS scoring is there, sir. Show both the group had a median score of 13, which represent moderate to severe stroke. Ranking scales from 0 to 6 indicate the different level of person disability. 0 means no symptom and 6 means death, and in between there is a different level of disease. This is also baseline patient characteristics data including the location of ICH, blood pressure, spot sign CT, and ECG troponin elevation during the stroke, and early ultra growth volumes. So as you see, the majority of the patient in both the group has a deep ICH. Like 85% in the placebo group and 88% in the intervention group. Only a small amount, 1 to 2%, had a infratentorial bleed. This suggests the study primarily focused on a patient with a deep brain structure of brain, with a deep brain injury, sir. Now, in case of blood pressure, sir, both the group has high blood pressure. Roughly 80 to 85% of the patient has a high.
Neeraj,
Yes, sir.
you don't have to go on explaining each and everything. Okay. Just say that the two groups are comparable with respect to all these parameters. If there is any difference, then specify. Otherwise, we can read it. It wastes a lot of time in explaining each and everything. Okay.
Okay, sir. So now, so this trial was stopped early because it stopped at the second pre-planned interim analysis for futility after 626 participants out of 860 participants randomized. So basically, investigator determined that if in the trial continue to its full enrollment, is 860 participants, there were a very low probability of achieving a statistical significant difference. So they also include ultra early recombinant factor 7 reduce the ICH expansion. ICH expansion by 3.7 to 5.2 ml, but it did not improve the 180 days functional outcomes, sir. Life-threatening thromboembolic event within 4 days were increased, which had a relative risk ratio of 3.4, means those who received the treatment were over 3 times more likely to experience these dangerous events as compared to the control group, sir. Another such signal of potential benefit were also absorbed in small and pre-specified ongoing bleeding with the treatment time period of less than 90 minutes and the CT spot sign is positive, sir. But the overall result was neutral and the trial stopped early for the futility. Means the overall trial was neutral, but the researcher noticed a signal of potential benefit in a specified predefined group. Those who receive treatment within 90 minutes of onset of symptom, that is ultra rapid treatment, and the person and the participant who has a CT scan positive for a spot sign. So this is the primary outcome. It measures the functional outcome at 180 days during the modified ranking scale, which assesses the patient level of disability, sir. In both the group, as you see, sir, P value more than the threshold value, that is 0.05 more than the threshold value, sir. So it clearly shows in both the population, nearly 40 to 46% of both the group patients achieve a good outcome, that is MRC score of 0 to 2, indicating functional independence. The P value in both the groups, sir, are 0.6 and 0.8 are significantly higher than the standard threshold of 0.05, indicate there is no statistically significant difference between the intervention and the placebo. Intervention did not appear to be improved functional outcome at 180 days compared to the placebo. Now, this is the secondary outcome, sir. Secondary outcomes, sir, it measures change in volume of bleed at 24 hours and the occurrence of life-threatening blood clots like thromboembolic events, sir. So as you see, sir, the modify ranking score at 90 days and modify ranking score at 180 days. In both the time period, a p value of 0.87 is mean. Results are almost identical between the groups, sir. In ICH volume, sir, in ICH volume from baseline to 24 hour in both the group, we will see the show the real difference in the p value, that is 0.001 and 0.01 in both the group, which means p value highly significant, which means it indicates that treatment was much more effective in controlling the volume of hemorrhage in brain in acute phase, sir. Now come to the safety outcome in the intention to treat population, sir. This table summarizes the safety outcome of clinical trial comparing a placebo group against the intervention group. It measures how many patients experience specific adverse event like blood clot or death in a new treatment, which increase the risk of sir. So as you see, the intervention group has much higher risk like 15 events versus 4 with a relative risk ratio of 3.4. The confident interval the 1.0 this suggests the intervention significantly increase the risk of early complication. So this is a forest plot, a standard graphical representation result of clinical trial across the various study. As you see, sir, in all these subgroup, the horizontal line crosses the vertical line, means the result is considered not statistically significant, except in times in last known or the spot cytocity in these two groups. Horizontal line does not cross the vertical line, means treatment effect shows some benefit by using the recombinant factor 7. The internal validity of this is, so internal validity means how we can say that the observation is truly due to the intervention treatment or not due to any bias or confounding error. The internal validity, sir, there are many factors which improve internal validity of any trial, that is randomization or the allocation concealment, sir. So they using 1:1 randomization, meaning participant has equal chances of being selected in the group or the placebo group, sir. Other than this, sir, allocation concealment means separating the people who prepared or labeled the kit from the people enrolling the patient. This prevents researchers or doctors from knowing which treatment a patient will get before they join, sir. Early stopping means, sir, early stopping means stop from after 6 randomize, reducing precision and power of modest function effect, particularly within the subgroup, sir. It means every patient the early stopping the trial was stopped early for futility after 626 of time. 60 patients were enrolled. Stopping early reduces the statistical power of a study, making it less precise, looking at small group or create a risk of false positive or over interpreting manner, sir. Also, dropout or exclusion and follow-up, sir. Almost every patient received their full assigned dose. Trial profile indicate nearly complete treatment delivered in both the placebo group and the intervention group. Also, to follow up at 180 in placebo group, there is three losses is there, and in intervention group, there is 4 losses with multiple amplification modifier ranking session. So only a tiny number of people were lost follow-up by day 80. They use multiple imputation statistical technique to fill a missing score for the ranking modified score, which have to maintain the intent final analysis. Now the performance and the detection bias. We have to avoid the performance and detection bias in the study by double blinding the study. Avoid performance bias or by using the standard analysis tool like modifier rankings, or we can avoid the detection bias.
Oh, சரிங்க சரிங்க.
So balance. Now balance, baseline balance, baseline balance indicate one. This protocol. So baseline balance for the core prognostic variable was similar in age, including age of 61, baseline ICH volume of 7 ml, and NIH's median score is 13. A higher proportion underwent CTPA in placebo 85%, and in intervention group that is 78%, sir. Baseline, sir, baseline means well study is designed, and timing, sir, mean onset to drug 100 minutes mean the drug was given in an average of 100 minutes after the stroke started. The goal is to stop the hyperacute expansion of bleed, and the treatment work best when given early, that is less than in 90 minutes, suggesting that even a small dip could reduce the drug effectiveness. Outcome assessment indicates what happened to patient after intervention. Did the patient improve or did any harm occur in the patient, sir? Statistical rigors included means how well the study is designed and interpreted using a proper statistical to ensure the results are valid or reliable, not due to change or bias. The trial use pre-specified plan in advance rule for when to stop the study or how to look at the data set. Now externality means how well the result of the study can be applied or generalized to the patient outside the study setting. That is, generalization of study result in real world. Now, affecting the external medicine population representative, that is the selected hyperacute moderate volume of ICH 2 to 6 mm with limited IVH and GCH more than 8. Exclude the anticoagulant related ICH and severe pre-stroke disability, reducing the applicability to many real ICH presentation. The study used a very specific group of population of hyperacute with moderate bleeding 2 to 60 ml and relatively high level of coverage. Exclude the patient on blood thin and those who already have a disability. System requirements. System requirements benefit likely depend ultra fast pathway, the ambulance recognition, rapid CT scanning, and rapid CT angio, and immediate treatment within 90 minutes. Such pathways are not universally available in most of the hospital, so the result might not be reproducible, sir. Care contents means trial result can be applied onto the resource limited region that lack the specialized ICU or high level of monitoring system. Imaging-based selections, the CT spot sign was not required at baseline. Widespread implementation of spot sign guided strategy would require near universal CT angiography in hyperacute ICS, which may not be feasible everywhere. The conclusion of the overall the moderate to strong due to robust mind, that is the strength of the study, and objective central imaging reads and pre-specified adaptive monitoring, but is limited by early stopping, futility, and inherently exploring the nature of a small subgroup signal are the weakness of the study. External validity is limited to moderate. Finding apply most directly to hyperacute treatment. Selected spontaneous ICH in system capable of treatment within 2 hours, ideally within 90 minutes, and are less applicable to the broader and later presenting the ICH population. Means the finding only rely in those patients who can be treated extremely fast, that is within 2 hours, but ideally within 90 minutes. The study is less applicable to those ICH patients who arrived late to the hospital, that is after several hours. Now the strength of the trial, sir. It was the largest randomized to date targeting the ultra early, that is less than 2 hours hemostatic therapy in spontaneous ICH. Double blind designed with central imaging reads rather than the individual local site, and the patient center validated functional outcome. Demonstrated biological efficacy reduce hematoma expansion while simultaneously quantify the thromboembolic event. Operationally programmatic across the diverse system, including the mobile stroke, means the study was designed to work in a real world environment, including the mobile stroke unit, not just a specified research center. What is the limitation of the study, sir? Sir, stop early for the futility, limiting power of the modest effect, and definitely subgroup conclusion. Because the clinical data shows that the treatment was unlikely to provide a significant benefit, and also there were not enough participants to prove if the treatment has modest benefit. It also makes it impossible to say that the treatment worked better for a specific subgroup or not. Highly selective population, shortest time window, ICH and IVH threshold, exclusion of anticoagulant related ICH, and that they all limit the generability of the trial. Means you cannot apply this result in a general population. CT-NG not required for all participants, reducing the uniformity of spot sign and complicating transition to biomarker guided strategy. Means we cannot use spot sign as a reliable marker to decide which future patient should receive the specific treatment. Increase early life threatening thromboembolic events constrain the risk profile, especially without clear functional benefits. Now, what is the implication, sir? Clinical implication, even when administered within 2 hours, recombinant factor 7 should not be adopted for routine spontaneous ICH because it did not improve vulnerability outcome, functional outcome, and increase the early life threatening thromboembolic events. Mechanical implications, sir. Hemostatic reduction in expansion of 3 to 5 ml was insufficient to translate into functional improvement at a population level, and reinforcing that surrogate biological success does not guarantee the patient-centered benefit. Pathway implications, sir. Potential benefit may be confined to a very small, high risk of ongoing bleeding phenotype, very early treatment and spot sign, but any future evaluation required a right code of ICH, pathway, and biomarker-driven enrichment strategy. Yes, like surrogate success versus clinical failure, the trial shows that reduced hematoma expansion. The trials shows that reduced hematoma expansion call this a biological marker, but we expect to improve the outcome. But actually, patient did not functionally improve. That is a clinical failure. Subgroup and clinic. So researchers look at subgroups such as those who got early treatment, that is within 90 minutes, and spots positive on CT showed some benefit, but results were not statistically significant. This benefit might be due to just chance. This benefit constants the increase early life threatening thromboembolic events, limit tolerance to means that even if there is a small biological benefit, it is still not. If there is a risk of early life threatening like thromboembolic event, patient clinically did not show the improvement. That is, if benefit is unclear and harm is real, the treatment is not justified. How fastest fits with other hemostatic strategies, sir? Sir, other drug like tadalafil acid has been tested in past in ICH. Fastest trial reduces the hematoma expansion in a certain limit, but primary outcome is not improving the patient, sir. Other than guidelines and this synthesis of fastest result is not practically not practiced in public unless strong benefit is proven. Modern evidence synthesis and ICH guidelines continue to recommend it against routine hemostatic agent used in spontaneous ICH. Specified indication trial reflected uncertain clinical benefit and potential harm. The 2025 European Stroke Organization and European Association of Neurosurgical Sciences Society recently published guidelines of management of ICH. System level subsequent evidence. It's a pooled analysis supported the time-sensitive bundle care, yield functional benefit in acute ICS, highlighting that the time is matter in ICS, sir, but the modifiable target might be physiological control rather than hemostasis of most patients. That is the time is brain cells in ICS, early BP control or rapid use of stroke care bundle show a better outcome. Therefore, the main modifiable factor is physiological BP control, not the clotting drug.
Are you done, Neeraj? Is this the end of your slides?
One more slide, ma'am.
In
Ma'am,
want
this is
of
the
time, no, in want of
okay, ma'am.
time, let's go
Ma'am,
to
this
the
is the
discussion
recent.
part of it.
Okay, ma'am.
Okay, quickly finish.
Ma'am, so take home message, ma'am. The fastest tested recombinant the factor 7 microgram ma'am. The fastest recombinant 80 microgram per kg within 2 hours to respond in ICH stop early for after randomized no.
You know what, Neeraj, your voice is breaking. We've read the slide. Why don't we come to the discussion part? Okay. Dr. Ankur, you want to start the discussion?
Yes. So Neeraj, in your own terms, if you have to, will you use this recombinant factor 7A? If yes, then why? I mean, if no, then why not? If yes, in which type of population?
Excellent.
I don't understand, sir. Your question, sir.
The question is directly related to the trial. See, if you have understood the trial, you'll be able to answer my question. I'm saying, if you receive ICH patients, right, will you use
Yes, sir.
recombinant factor 7A to improve its functional outcome of the patients? If yes, in what category of patients? If no, why not?
Sir, yes, sir. I will use, sir. But in those patients who comes early, sir, in those patients who comes early within 90 days or within 2 hours, I can use recombinant factor 7 to reduce the hematoma expansions. But I cannot use in those patients who came later, sir.
How will you take the consent from this patient? What will you say? Why are you giving recombinant when the literature says it doesn't improve the functional outcome?
Ma'am, it doesn't improve the functional outcome, but it improved the hematoma expansion. If the patient comes in earlier, then it will improve the hematoma expansion. So I can explain the patient.
But it didn't
which is good
translate,
for,
no. Hematoma expansion.
Yeah, you are
did not
interested in
translate.
hematoma or you are interested in clinical outcome?
Definitely, sir, clinical outcome, sir.
So then if it is not improving, what is the point of giving it? Plus, you are increasing so many problems, thromboembolic events. Did you see it was 3 times higher in
Yes,
that
sir.
group in which the
Drug is given,
was
sir.
given?
Yes, sir. So I should avoid, sir, from now.
That is what the trial is saying.
Yes, sir.
See,
I will still give in one set of group, one
Yeah.
set of patients.
In what patient, ma'am?
You tell
You
me
tell
first. You
which group of
presented.
patients?
Ma'am, I think in those patients whose CT spot sign, I think it's positive.
So why did this study have a neutral effect?
Neutral, yes,
It
ma'am.
has shown a subgroup in which it works, but then the overall result is neutral. Why did that happen? Where did the methodology go wrong? So to
Because,
begin
ma'am,
with, CT
benefits are
angio
less
was
in
not
this.
essential. CT
Yes, ma'am.
angio was not essential. The inclusion criteria was CT scan, CT C plus, C
Yeah.
minus, and CT
Got it.
angio was done in the intervention arm in 80%. So close to a quarter, if the CT angio was done and had spot sign, the positive result would be inflated. It might come to the statistical significance. And moreover, it has been stopped prematurely. So you do not know exactly if you had taken up all the patients intended. This is for whole sample size, the result would have been maybe different. So I will still give to someone who is come within 2 hours window period, has CT angio positive, is less than 70 years of age, and is refusing any other treatment. He doesn't want to get operated. What else do you have? A medical therapy which may be beneficial in the context given is factor 7A. So I will take a consent saying out of surgery, if you want any sign of improvement, I have one choice which I can offer you, and this is it, with an additional risk of thromboembolism. That's how the consent has to be taken. What do you say, Ankur?
Yes, exactly, ma'am. Rather, they're planning, their next study would be these inclusion criteria who are coming to you within 90 minutes or 2 hours, who all have a CT angio done, in which you can say that maybe it is coming positive. I mean, the CT spot sign is positive, and they'll be properly randomized into two groups. They'll be studied rather than the entire groups where half of them did not have, or more than half did not have the CT angio done, and so the result was not very significant. But still, the questionable efficacy is there because thromboembolic events do increase after giving these drugs, and there is always a problem. That is why more studies are required to further before they are putting in the guidelines these drugs for improving the functional outcomes of these patients.
So, Neeraj, in methodology, can you give me one positive and one negative? This was a robust study as far as methodology goes. You don't put slides. What you have understood. Give me one positive and one
Yes,
negative
ma'am.
in the methodology. You have to tomorrow choose a patient with ICH. How will you decide?
Yes, ma'am.
What was one positive sign?
In what format?
The study, how it was conducted. Based on that, if you
Yes,
have
ma'am.
to consider factor 7 for a patient who is coming to you within 2 hours, how will you manage it? In India, someone has
Okay.
come to your ED within 2 hours and you want to give the medicine. How will you be able to do it based on the methodology? Because this study gave you one factor which makes it easy for you to do that. What is that factor according to you?
Ma'am, I think the volume of bleeding is important, ma'am.
What did they say about the volume? In fact, that is a
There is
negative thing.
amount of
What did they
ICH.
say? The volume was fine. 3 ml to how much? It's 80 ml, no? 70 ml something. But what did they say about IVH?
70 ma'am.
1/3 of the lateral ventricle. Then there is so many other criteria quantifying the amount of blood in the ventricles. You as an intensivist will be able to do it. And in the whole study, in every center, there is one senior radiologist who's seeing at this CT scan and deciding whether IVH volume is in the inclusion criteria or not. That is not generalizable for easy day-to-day practice. And spot sign, yes, we agree, we must be able to spot it. But is it always possible for us? It may not be. So you need a radiology help all within the matter of this small time frame of 2 hours. So that is very, very restrictive as far as we are concerned. If somebody enters into our ICU and in the time frame to give, it's a little stifling to get all that done. But one advantage was, did you know that there was an emergency consent possible? Before you read this study, did you know that you could take an emergency consent? What is emergency
No,
consent?
ma'am.
In this study, the US centers waived consent because you had to enroll them within 2 hours. And the other European and Asian nations, they did something called emergency consent. What is emergency consent? Because it is an emergency drug and has to be given off at the stipulated time, you give it off. And then go back to the family and the patient and the family and get their signature that you have been given. I didn't know this existed.
Okay,
So that type of a consent
it.
is feasible if you're looking at a very small, short frame of time for giving the drug. Applicability, we already discussed. So what do you think? Where are we with
Got it,
respect
ma'am.
to factor 7? Is this the end of the story? Factor 7 shall never be tried even on a experimental basis. What should happen in future?
Ma'am, using of factor 7 has so many side effects rather than the benefit effect. So I'll always be aware of before using these
What side effect? Only one, no?
in any ICL
Thromboembolism,
patient.
less than 5%. Compared to hematoma
Yes, ma'am.
expansion, the 5% risk of thromboembolism, can you not take it up? Weigh the risk and benefit ratio, what do you say?
Ma'am, I can
Already Ankur
use it in
answered.
those patients who comes in earlier.
Already Ankur answered this question. In the subgroup that they looked at, the CT spot sign positive, less than 70 years of age, that small cohort has to be relooked.
Small
So
cohort.
factor 7 is
Relook.
not dead and out.
Yeah.
Now the trial has to be done for this small cohort of group and seen whether it does. So the RCT has failed because you have taken a very composite group, and it has succeeded in the fact, and in the it has succeeded in the fact that it has provided you with the cohort which should be reanalyzed in another trial. So, how 80% of patients CT angio was done and 25% had spot sign positive. Quarter of the patients would be successful in this trial. That is a huge number. So
Yes,
it is not completely out. It has given you a ray of hope. Another well-designed study has to be taken.
Got it, ma'am.
Ankur, you want to add something?
Yeah, so basically that's what was the outcome. So is it applicable to India as a whole, Neeraj? What do you think? At its current state,
Sir,
if you are
in
sitting in
India,
a
like
developing country, yeah, go ahead.
No, sir, in India, like country, we don't have such kind of infrastructure whose in which we trial rapid treatment or city angio like facility is available all over there. So it is slightly difficult, sir, in India.
So based on this information that we have got, we are not, I mean, we still cannot advocate this drug. This cannot be put into any kind of guidelines to suggest that it might, because see, overall, it is not improving the outcome, right? Most of the patients did not, I mean, had that early CT angio or that. And even if the hematoma reduction is slight, say 4 to 5 ml or 6 ml, that might not, correspond to a better
It might
outcome
not
overall, right?
significant.
That is what it showed, right?
Yes, sir.
So it's
Yes.
a very, very stringent kind
Yes,
of
sir.
population and very, very strict rules if you have, but it's practically next to impossible in India. But let's see further what the studies have to from the West comes and they give us a role of. Otherwise, till now, this cannot be advocated as a whole to general population, right?
Got it,
Fellows
sir.
in the group, you want to ask any question?
Yeah, good evening, madam. Thank you. So, as we discuss, everything has to be individual.
Dr. Yash, we can't hear you.
Early usage is obviously much more beneficial, as was shown in the study also within 90 minutes. Imaging selection already focused CTA spot sign is must. In actually about 15-16 years back, I was at Max Saket in the stroke unit and we were using it quite often. Then came the NICE registry and the risk of thromboembolic events. We rarely saw any thromboembolic event. We must have used close to 74 patients in 3.5 years. We presented also at ESICM our data. Now, in this age, we have to individualize which patient requires, if it is early CTA sign positive, not on other anticoagulants. So as madam already pointed out, it should not be written off. We should find the right subset of patient to be used in. Thank you, madam.
Thank you.
Thank you.
Other fellows,
Thank
it
you,
was
sir.
a well done paper. You described it very well. Those who were listening, you want to ask something, clarify doubts, please do. Ankur, you want to give the closing statement?
Yes, so basically we understood from this that if you have to say that factor 7A cannot be advocated for everyone, as you know, and it reduces hematoma expansion but does not improve the functional outcomes overall, and may increase the thromboembolic risk if it has been, if only in two particular subset of patients, that is very early presentation, in whom the CT angiography is done, spot sign is positive. There it shows some kind of hope, and further trials are recommended or are necessary to quantify that this would improve the outcome in those subset of patients without increasing the side effects. So that's my take on this.
Thank you, Ankur, and thank you, Neeraj. It was a very well presented, except for the voice problems.
Thank
But
you.
yeah, it was well done, setting a good tone for the next journal club to come. Thank you all who listened to
Thank you.
this and who participated in this journal club. Thank you. See you all after 2 weeks. Bye.
Thank you, ma'am. Thank you, Ankur, sir.